Good morning, students. Myself, Dr. Tripti. So, a brief introduction about me before we proceed to the main lecture today. So, I am Dr. Tripti and I am an MD pathology. I did my PG approximately in 2021 completed. So, before we move on to the topic, I just want to remind you that you already are doctors. You have completed your MBBS. So, just be assertive about things. The topics are simple. You just have to concentrate and know about the what is required to crack the MCQs because we are preparing for the NEET post graduation exam. Okay, so today's topic is acute myeloid leukemia. It is this topic holds the weightage of approximately 2 to 3 questions. The questions are basically in the form of clinical scenario. Secondly, in the form of the direct questions, and the third are the picture-based questions. So these are the three type of questions you will be getting in this acute myeloid leukemia topic. So we proceed to the uh, depth of this topic. So acute myeloid leukemia. This is the malignant neoplastic proliferation of the immature cells that of the myeloid lineage. So as the name suggests, the myeloid, so the neoplastic cells will be of the myeloid lineage. It can be in the peripheral blood, it can be in the bone marrow or in the extramedullary tissues like spleen. Okay. They crowd the marrow to prevent the normal cells to proliferate. Obviously, when one lineage will be like proliferating more, so the other lineage will get suppressed. So they crowd these malignant cells crowd the marrow to prevent the normal cells to grow. So the genetic makeup is basically responsible for the prognosis. So as you can see, this is the hematopoietic stem cell. It gets divided into the lymphoid progenitor and the myeloid progenitor. So there are, in the AML, there is the enhanced proliferation and the so enhanced proliferation of the myeloid progenitor leads to these type of cells like neutrophils, eosinophils, basophils. Okay, so this is seen in the enhanced proliferation is seen in the CML. But when and if there is enhanced proliferation of the red cells, it leads to polycythemia vera. Of the platelets, it leads to essential thrombocythemia. And in the lymphoid progenitor, if there is the enhanced proliferation of the B lymphocytes, it leads to your lymphomas and of the platelets. Now, if there is one more thing, there is the differentiation block. When there is the enhanced proliferation of these lymphoid progenitor, but there is differentiation block. The differentiation, further differentiation to lymphocytes and the plasma cells is blocked, then it leads to what we call as the acute lymphoid leukemias. Okay. Again here, whenever there is the enhanced proliferation of the myeloid progenitor, but the differentiation block is at the level of the precursors like the myeloblasts, promyelocytes, and the metamyelocytes, it leads to the formation of acute myeloid leukemias. So always remember, there is not one thing which is there in acute myeloid leukemias. There are two things, that is the enhanced proliferation along with the differentiation block. Differentiation block to the maturity cells. Okay. So the pathophysiology is of two types, that is, it could be unknown etiology, which is known as de novo, and the myelodysplastic syndrome progressing to AML, which has got the worst prognosis. So pathophysiology, it could be exposure to genotoxic agents and hematological disorders like Fanconi's, PNH, aplastic anemia, or it can arise de novo, or it can be a complex malignancy with genetic, epigenetic, and phenotypic heterogeneity. Now there is two-hit model of leukemogenesis, that is the gain of function mutation of tyrosine kinase. These can be among these genes, that is the gain of function mutation, that is the c-KIT, NRAS, KRAS, BCR, ABL, which leads to the enhanced proliferation. And the loss of function of transcription factors like PML-RARA, AML1, CBF beta, all this leads to differentiation block. So as I told you earlier, there is two things, that is the enhanced proliferation and the differentiation block. So gain of function mutation of tyrosine kinase leads to enhanced proliferation, and the loss of function of the transcription factors leads to the differentiation block. It progresses to acute leukemia. So in acute leukemia, we will be studying about the blasts. The blasts are basically, these are the immunomarkers, as you can see. They are CD34, CD13, CD33 positive. Okay. So the blast is CD34, CD45 positive. Okay. And these other cells are given accordingly. As you can see here, CD33 is the main for the blast, and CD34, CD13, CD45, and HLA-DR. Okay. So what are the clinical presentations of anemia? They can be bleeding manifestations. Anemia because there will be lack of hemoglobin, RBCs are getting broken down. Bleeding manifestations because of the platelets getting affected. Infections, fever, pain and tenderness of the bones. Lymphadenopathy. As I told you, there would be there could be proliferation of the cells in the other sites as well. That could be spleen, liver, which can lead to splenomegaly, hepatomegaly, and the lymphadenopathy that is in the lymph nodes also. So, and there could be gum hypertrophy and the meningeal involvement. These clinical things are important so that you can finally go to the diagnosis. So lab investigations are based upon the morphology. What are the type of the cells you are seeing? The cytochemistry is basically the special stains you are seeing. The immunophenotyping, that is the IHC, and the flow cytometry and the cytogenetics and the molecular studies. These all are basically nowadays we for making a diagnosis of AML you require morphology and the cytochemistry. Okay. And further are the IHC and the flow cytometry for the specific diagnosis and differentiating it from the malignancies. So bone marrow will be hypercellular or hypercellular. There will be the increased blast greater than 20%. What happened in the AML was there was a criteria that is the blast should be 20%, but that is no longer followed except in the two conditions, that is the BCR-ABL1 and the SEPA mutation. These are the only two conditions, and mark it as this is a PG question, PG need direct question. In which of the two conditions the blast percentage 20% is required, greater than 20% is required. So it is required in only two conditions, that is the BCR-ABL1 mutation, number one, number two, SEPA mutation. Okay, fine. So as you can see in the granulopoiesis, it can be either of the form. It can be suppressed or it can be adequate with dysmyelopoiesis. That is, it can be dysfunctional. Myelopoiesis can be there. Erythropoiesis, it can be suppressed, adequate, or reduced. And mega, same way, reduced, normal, or increased. So as you can, you just have to understand that is the granulopoiesis, we are talking about the WBCs type of cells. Erythropoiesis, we are studying about the RBC type of cells. And the megakaryopoiesis is something we are studying about the platelets. So this cell, what is the, as you can appreciate here, these are the cells. These are round to, round to oval type of cells. These are very larger than the size of the RBC, okay? Now what you can see, the membrane looks not very well defined, and the chromatin is the cytoplasm is blue in color, and it is very it can be abundant or it can be less anyways, but the cytoplasm of the nucleus, that is the chromatin of the nucleus is opened up. With opened up, I mean to say, usually the cells have a clumped type of a chromatin, but here we have an opened up type of chromatin. One more thing I would like to tell you is this: there is the presence of the OR rods, which is classically seen in AML. Okay, so if there is an OR rod and you get what is the diagnosis? The clear-cut diagnosis is AML. Okay, these are nothing but these are actually the remnants of the ribosomes. So you can see here, this is basically a myeloblast. So how will you define a myeloblast? This is round in shape. Okay. First of all, whenever we describe a cell, we have to describe it in various, headings. So the shape is round to oval in shape with the size approximately 3 to 4 times as the size of the RBC. The cytoplasm can be, so we will say irregular membrane. The cytoplasm can be it can be scant to moderate. Then we have the nucleus. The nucleus is irregularly shaped with the opened up chromatin, and there is the presence of the prominent nucleoli. 2 to 3 nucleoli are present in the myeloblast. And if there is the presence of OR rod, it is a classical myeloblast. Sign of AML. Okay, so these cells are myeloblasts. So see the chromatin, see the nucleoli, see the size, and try to differentiate it from the others. So the special stain which is required for differentiating, sometimes the morphology alone is not responsible for differentiating. So you require the special stains to differentiate. So this MPO stain stains the granules of these cells, and it is strongly positive in myeloblast. And as you can see, PAS stain stains the glycogen and the glycolipids, and it is lymphoblast positive. So whenever you are told what is the single test you will advise to the patient for differentiating a myeloblast from a lymphoblast, that would be the MPO. Okay. The MPO is the single test you will advise the patient to differentiating it from the myeloblast. Then SBB. SBB is again is strongly positive in the myeloblast. NSC, it is positive in the monoblast, promonocytes, and the monocytes. So NSC is the marker of monocytic lineage. PAS is the marker of lymphoblastic lineage. MPO and SBB are the marker of the myeloblastic lineage. Okay, so basically, always remember what is the type of cell and what is the special stain you are gonna study. Okay. Now, see, there was a recent WHO fifth edition has been launched in 2022, I guess, and then there is a certain mutation changes have been done into the classification. Earlier, it was acute myeloid leukemia with recurrent genetic abnormalities, but now this has changed to the defining genetic abnormalities. As you can see, you have to remember it, that is there is the genetic abnormalities. When we talk about, there is basically six of the fusion genes, three of the rearrangement genes, two mutations, and the other myelodysplasia and the other defined genetic alteration. So to remember it, there are six of the fusion, which are PML RARA, RUNX1, RUNXT1, CBF1, MIH1, DEC and NUP214, RBM15 and MRTFA, and the BCR-ABL1. Okay, so easy to remember, six fusions. Okay, and the three rearrangements, KMT2A, MICOM, and the NUP98. Okay, then the two mutations, NPM1 and the SEPA. So, and the myelodysplasia related and the other defined genetic alterations. So now I earlier told you that the no longer criteria of 20% blast is followed. So again, the question arises, which are the two acute myeloid leukemia with genetic abnormalities which doesn't follow that, which has 20% blast criteria still valid? Are these two, that is the BCR-ABL1 fusion and the SEPA mutation. So these are the only two which is having this. Okay. Now we had by the differentiation, that is the minimal differentiation, without maturation, with maturation, basophilic, myelomonocytic, monocytic, erythroid, and the megakardioblastic. So in general, the AML is divided into two, that is with the defining genetic abnormalities and by the differentiation. Now, why I'm stressing upon sometimes the updated questions are always there in the exams, but sometimes what they give you is basically they don't give you which type of AML they're talking about. They will give you just number M1, M2, M3, M4, M5, M6. Okay, so it is that way: M1, M2, M4, M5, M6, M7. Okay, and this is M3. I think I have mistakenly missed it. Okay, so this way it has to be marked up. That is the M1 wise also. Okay. Now we come to the defined genetic translocations. So AML with RUNX1, RUNXT1, it has the predominantly neutrophilic maturation. There are the large blasts with abundant basophilic cytoplasm, and they contains the eosinophilic granules. As these, the neutrophilic maturation is there, the eosinophilic granules are obviously will be present. It is 1 to 5% cases of the AML, and it is seen in the younger patients. So as you can see, these are basically the blast cells are there with the granules. They are positive for CD34 and they show maturation asynchronous. That is a co-expression of CD34 and the CD15. It has complete remission and the long-term disease-free survival. Then we go to the inversion 16, that is CBFB and MIH1, monocytic and granulocytic differentiation, abnormal eosinophilic component, 5 to 8% of the younger patients and lower and older adults. Now, as you can see here, it is the leukemia in version 16. There are abnormal eosinophils, one with large basophilic colored granules are present. Okay. Now, cytochemistry, they show MPO positivity, but they are CAE reaction negative is eosinophils normally, okay? But here, they are faintly positive in abnormal eosinophilic, okay? So, NSC may be positive or weaker, but a 3% blast show MPO positivity, and CAE, it's faintly positive in abnormal eosinophils. See, as you can appreciate here, the brown color indicates the positivity. So 3% blast show MPO positivity and the CAE reaction is positive. This is the CAE reaction and this is the MPO reaction. Immunophenetic immature blast of CD34 and CD117 positive and granulocytic lineage की तरफ अगर जो हमारा population proliferate कर रहा होगा तो 13, 33 and 15 positive and MPO positive. And if it is monocytic, as you can appreciate, there is 11, 14, 4 and 64 and 36. It has favorable and high survival rate. Now the main, which is the most favorite of the NEET PG examiners are this acute promyelocytic leukemia with the PML RARA. Okay, so it is the acute myeloleukemia with the abnormal promyelocyte predominance. It can be hypergranular or the microgranular. Okay, it is present in younger patients. What I am telling you is very important. The patient usually presents with DIC and increased fibrinolysis. The prognosis is favorable if the treatment is given on time, if the diagnosis is made on time, and if favorable if the patient may go to DIC, not respond to medications, and still may not be able to survive. But if you can diagnose this APML and give the medication on time, the prognosis is favorable. Okay. So these are the type of the cells which you could appreciate. These are the cells. These are called as the buttock shaped cells. Can you appreciate? These are basically, there are two forms, that is the hypergranular and the microgranular. As you can see, there is so many increased granules inside and there is bundles of numerous or rods can be seen. Okay, and in this, the bundles of all rods which are seen, these basically cells are called as the Fagot cells. Whenever there is a bundle of the all rods. Now, in this, there is a in this these cells are APMS cells that is called as the buttock shaped cells. You appreciate the two buttocks. So there are basically they are having less eosinophilic granules, but they have a predominant buttock shape, that is the two lobed type of cells. Okay. Cytochemistry, again, these are again MPO positive, and you can see the this part is getting more positive, which are basically the two buttocks. Again, bright expression of CD33. Most expressions show CD117. Granulocytic differentiation markers are negative. CD64 expression is common and CD11 CC in some cells. Again, you can appreciate this is basically the uh, flow cytometry recording, which says that it is positive for CD34, CD45, CD19, CD5, CD117, CD14, CD13, and 33. Okay. Okay. Now, AML with translocation 911, that is the KMT2A rearrangement. It has got the monocytic features. It occurs at any age and it can occur in the pediatric and the adult and men cases. It again presents with the DIC and the myeloid sarcoma. Here the blasts are basically the monoblastic cells. Okay, they have very abundant cytoplasm and can you appreciate the round type of nucleus they have got? Although they are blastic cells, but the cytoplasm here quantity is very, very abundant. And it is slightly blue in color. They are MPO negative, but they are NSC positive. So the monoblastic cells are NSC positive. That is the marker which we differentiated monoblast from the myeloblast. That is the NSC. Again, it shows monocytes are seen, promyelocytes with very pale type of a cytoplasm, and the fine acidophilic roots. And what you see in the monoblastic nucleus is the convoluted form. That is, it has got very convoluted type of nucleus. You can see that there are many folds which are coming into the nucleus, unlike that of the myeloblast, which has got a basically opened up type of chromatin. Here the chromatin is convoluted. That is, the nucleus is basically folded type of a chromatin you get. Okay. And the NSE is highly reactive. Strong expression again 33, 4 NHLADR, and low expression of the 34 and the 13. Now it is NAP24, it is the fusion product DEC in NAP24. AML with 21% peripheral blood or bone marrow blast is no longer criteria. With or without monocytic features, it is associated with basophilia and it presents with pancytopenia. As you can appreciate, these are the coarse granules which we can see. Blast positive are there, again expression of these cases. Okay, and these half are TDT positive. Now, again with the MECOM rearrangement, these are present with or without of the 20% peripheral blood, 20% blast. It occurs most commonly in adults. It has got hepatosplenomegaly and the pseudopelvic abnormality. As you can appreciate here, there is the increased blast and implicated non-lobated megakaryoblast. Blast are positive for 33, 34, 13, KIT and HLA-DR. They are 38 positive. And the 41, 61, which are the megakaryocytic markers. Now the megakardioblastic, that is the RBM15 and MKL1, it is seen and associated with the trisomy 15, trisomy 21. So basically, sometimes this question comes up, which is the AML associated with the trisomy 21 is the megakardioblastic, that is the RBM15 MKL1. Okay. As you can appreciate, these are the megakaryocytes, which are enormously large in size. The chromatin is again clumped up chromatin. uh, like the chromatin again is like a sort of somewhere it is clumped, somewhere it is opened up. It is basically the bone marrow picture, which is showing that is the extensive replacement of the bone marrow by the blastic type of a cells. Okay. Sudan Black B and MPO is negative. Okay. There's the expression of the 13, 33, 34, which is seen in the blast. There is the evident expression of 19.7 at TDT. Okay. AML M7. Now, BCR-ABL1. One of the other disease which is having the BCR-ABL1 translocation is the CML. Okay. So, this has to be divided and differentiated from the CML because both shares the common BCR-ABL1. Okay, the chromosomes. So basically, in the BCR-ABL1, whenever there is the fusion, whenever there is the fusion of the BCR-ABL1, it can lead to either acute myeloid leukemia, and this is the only AML which requires greater than 20% blast to be called it as the acute myeloid leukemia with BCR-ABL1 fusion. Okay, so it presents with the leukocytosis with the blast predominance. And again, it is the mutated NPM1 that involves the uh, most common recurrent genetic lesion in AML. Suppose the patient is coming with the recurrent cases, so NPM1 is the one. It has got myelomonocytic and monocytic features. And the characteristic of this NPM1 is the presence of the thumbprinting blast. Okay, just a sec.
Hello, doctor. Hello.
This is the presence of the thumbprinting blast, as we can appreciate. This looks like as if somebody has thumbprinted. As you can see, a smaller amount of semicircle and the multiple rounded circular type of blast. This is typically seen in the MPM1 mutation. There is the high expression of CD33 and the low expression of CD13. Now we are having is the SEPA mutation. It is seen in the patients with or without maturation, and it is basically, it has got the favorable mutation. In this, there is lower LDH. Now, acute myeloid leukemia with mutated NX1, it is basically, it has got the worst survival. So, which of the basically AML got the worst survival is with the mutated RNX1. Now, this entity earlier in the fourth WHO hematolymphoid malignancy, in this it was myelodysplasia related diseases. Okay, now it has changed to myelodysplasia related changes. It is now changed to acute myeloleukemia with myelodysplasia related. So basically, greater than 20% of peripheral blood or bone marrow blast, morphological features of myelodysplasia with a prior history of myelodysplasia, and it occurs in elderly patients. And now the criteria is basically three criteria are there. That is the greater than 20% blood or myroblast, or any of the following, that is the history of MDS or the MDS related cytogenic abnormalities, or the absence of any radiation or the recurrent cytogenic abnormality. So basically, key changes include removal of the morphology alone as a diagnostic premise to make a diagnosis of AML MR. Only the morphology is not sufficed to basically calling his as acute myeloid leukemia, which is myelodysplasia related. There is an update of defining cytogenetic criteria that I will be sharing, and the introduction of mutation-based definition based on set of A genes. These are the A genes, and the presence of one or more cytogenetic or molecular abnormalities which will be listed, or the history of MD or MDS MPN are required for diagnosing it as the AML-MR. So basically, only the morphology alone is not the criteria for defining it as the AML-MR, but it has to be the one or more of the cytogenetic or molecular abnormalities plus or history of MDS or previous MDS or MPN. So basically, you have to remember this because sometimes the questions are framed. He is only the morphological criteria sufficient for calling it as MDS AML MR? No, not the morphological criteria. The morphological criteria, along with the cytogenic abnormalities, one or more, or the history of prior MDS or the MPN, then you can call it as AML, myelodysplasia related. So the changes made in this recent one is the defining cytogenic abnormalities is the complex karyotype greater than 3 abnormalities, that is the 5q, monosomy 7, 11q, 12p, 17p, and the isochromosome 17q. So these are basically called the defining cytogenic abnormalities, and the somatic mutations could be in these type of the genes. Among these 8, the cytogenic abnormalities can be there. So this is the myelodysplasia genus. This is the multilineage dysplasia. Okay. So you will see the hypogranular neutrophils with clump nuclear chromatin. So there will be the dysplasia in the disordered arrangement, disordered proliferation. Okay. In the all the three lineage, that will be in the myelin lineage, then the erythroid lineage, and the platelet lineage. So you have to make lineage, make a cadiocytic lineage. So in the all the three lineage, there will be the myelodysplasia related changes. That is why it is called as a multilineage dysplasia. So basically, there will be the hypogranular neutrophils with clump nuclear chromatin. There will be erythroid precursors with the irregular nuclear contours and the megakaryocyte present. Okay. There will be CD14 expression and the decreased expression of the HLA-DR, and it has generally got poor prognosis. So basically, this what we are talking about is the myelodysplasia related AML with myelodysplasia related has got the poor prognosis. Now, therapy related, after therapy, uh, uh, acute myeloid leukemia can be present. That is it can be a complication of cytotoxic chemotherapy or radiotherapy taken in the case of any of the neoplastic disorders. It accounts for the 10 to 20% of the cases. The alkylating agents which are cytotoxic in nature are the melpha, cyclophosphamide. Ionizing radiation could be there, and the other topoisomerase 2 inhibitors and the metabolites. So any of these agents can lead to the basically it can manifest into the acute myeloid leukemias. As you can see in this, there is the large cells with such a type of chromatin that is seen in the therapy related acute myeloid leukemias. Okay. It is generally positive and the prognosis is very, very poor. Now we come to the acute myeloid leukemia with the differentiation. So basically there is the first is the minimal differentiation, that is the M0. It accounts for less than 5% of the cases. There will be pancytopenia and there is blasts are varying in size and there are no features of differentiation for the progression. Okay. So the marrow is completely replaced by the blast. So that is AML with minimal differentiation.
Ma'am,
MPO with
sorry to interrupt. Like we have less than 5 minutes, so if you more or less we got the idea, like your teaching style and all that. If you have
okay.
MCQs, you can discuss. Like, have you included MCQs?
Hmm. Okay, fine. I will discuss the MCQs just a sec.
Yeah. Right.
Just a sec.
I mean,
The MCQ number one. This is a 46-year-old patient admitted in ICU with the features of sepsis. Despite all antibiotics treatment, patient is not
yes.
recovering and the high TLC
Ma'am,
indicates.
your screen is not properly visible. If you can,
Yeah, I will.
just
Is it okay?
no. If you can double click this, you can increase the.
Double click the screen. Okay. Um, are you able to
Like
see?
last time you maximize the screen, right? Like that, if you can do, you can exit this format background, doctor.
Okay.
This one, that format background.
Oh shit.
It's
Have I?
okay. You can share again.
Okay. Are you able to see?
Yes, yes.
I'm sorry, I'm not
It's okay. It's
so
okay.
much.
The first one, I guess. This is not the one. AML unsaved. That one, I guess.
Okay. Okay. Are you able to see now?
I'm able to see the screen, but not the PPT. You have not opened the PPT yet.
Is it okay now?
No, screen I'm able to see, but you have to open the PPT.
I have already opened actually.
PPT I'm not able to see.
Okay. Mm, just a sec.
हाँ ಅದು ಸ್ಟ್ರಕ್ ಆಗ್ಬಿಟ್ಟು
Um,
ಒಂದೇ ಅಲ್ಲ ಶಾರ್ಟ್ ಕಟ್ ಅಲ್ಲ Not the shortcut, doctor. The AML. This is just 1 KB file. Yeah. Just a second. 3 minutes ಇದೆ ಇದು ಡೆಮೋ ಕ್ಲಾಸ್ ಎಂಡ್ ಆಗ್ಬಿಡುತ್ತೆ ಅವ್ರಿಗೆ MCQ ಒಂದು ಡಿಸ್ಕಸ್ ಒಂದು ಸೆಕೆಂಡ್.
To see something or am I able to do it?
Yeah, only your screen is visible, but you have to just open the slide now.
Okay. Are you able to see now?
Yeah, you just have to open that AML. You have to open that file.
Are you able to see now?
No. Now this anyway 1 minute time is almost getting over. We'll do one thing.
Hmm.
Can I save this recording and then are you available now, doctor? Like in 10 minutes, can we just rejoin and do 5 minutes of MCQ discussion if you are free?
Uh,
Otherwise, it is
I-
fine.
I'm not able to. I don't know why I'm not able to share the screen.
No, this is
So,
not opening. There is some error in this file, this PPT file.
okay, fine. So we end this meeting and then again re-log in.
Yes,
And
I'll
then,
just save this recording and then I'll get back to you.
okay, fine, done. Okay, take care. Okay, thank you.
Yeah, thank you.